Thank you, Elena, for giving me the opportunity to present a case today. I was asked to present a case that focuses on the management of cancer-related symptoms. And so we've selected a case that I think nicely highlights one of the major challenges we face in our patients undergoing treatment for esophagogastric cancers, which is that of dysphagia. So the case is a 56-year-old man. He initially presented with 3 months of dysphagia and 40 pounds of progressive weight loss. He underwent endoscopy as shown here, and this revealed a large fungating mass of 34 centimeters extending into the GE junction, with pathology showing squamous cell carcinoma with moderate differentiation. He had imaging including a PET scan which showed FDG-avid thickening at the GE junction, as well as several lymph nodes, including celiac and retroperitoneal lymph nodes. His case was presented to the disease management team, and consensus decision was to proceed with systemic therapy, given the concerns for metastatic disease with the RP nodes. So he started treatment with chemotherapy and received 6 months of chemo with improvement in his dysphagia and weight loss. And repeat scans show no metastatic progression, and so he was referred for consolidative chemo-RT, which he completed with the plan to go for surgery. But unfortunately, a preoperative scan showed new liver metastases as shown here. And then subsequently, this patient developed severe dysphagia and ongoing weight loss. This highlights a major challenge that we face in patients, and the question for this patient is, what is the next step in managing this patient's dysphagia after he's already received chemoradiation? Do we proceed with surgery? Do we consider endoscopic management, such as stent placements or photodynamic therapy, or does he need a feeding tube? So I'd like to open this up to our panel to discuss.
Dr. Ilsen, would you like to comment?
Well, I think, the patient's already gotten radiation, and I think Daniela can comment, but we rarely perform surgery for palliative intervention. I mean, it's a morbid surgery and leaving gross disease behind, and the development of liver metastasis in the short term is very ominous. So brachytherapy is really for superficial disease, which doesn't apply here. So I think probably a stent would be for symptom palliation, and you could decide about a feeding tube later. Additional chemotherapy is likely to have a low response rate.
Hans and Pari, you know this patient very well. And so I just wanted to kind of get your opinion on stent versus feeding tube. What are some of the options here?
Well, I think this highlights what we struggle with on a day-to-day basis in these patients. And in our own GI service morning rounds, we struggle with this all the time. And I think perhaps the important thing that we try to consider is what are the patient's wishes. And very often patients will tell you that they don't want a feeding tube, or that they want to continue to be able to eat. But on the other hand, sometimes we have patients who are elderly and they don't have a great appetite, and certainly it would be terrible to put in an esophageal stent for somebody who has no desire to eat, where we're giving them the risk of doing the procedure, and the stent may be placed well and function perfectly, but they don't eat. And so, we try to think about these things when we consider which approach. And, I wish I could say that this was an easy decision and that all patients like this should have an esophageal stent placed. And that, this is a very rapid and quick procedure. We put it in, the same day they can swallow and they can go home and eat normally. But in contradistinction to photodynamic therapy, I just sort of spoke about this and showed you how we used to do it, and yet we don't do it very much anymore other than this one clinical trial. I think I spoke too much already, but I think in the majority of patients I would probably prefer to offer them a stent, but I would consider their wishes, and if they have no desire to eat, I would probably insert a feeding tube.
Pari, what are your thoughts about post-stent bile reflux and acid reflux, and how do we deal with that?
Yeah, so in general, esophageal stents are really well tolerated. Most patients don't feel the stent. They feel happy to have the ability to eat again. I advise my patients that though they can swallow, swallowing is never going to be the same prior to having cancer. And so we do recommend things like soft diet. Once the stent is placed, most of the time the stent will traverse the GE junction. And so that does result in a symptom of acid reflux. You no longer have the valve intact in order to prevent from acid reflux. There'll be significant symptoms of that. Again, most patients are able to medically manage that or tolerate that with lifestyle modifications and medications. So we advise all patients to go on daily PPI therapy, to sit up when they're eating, to sleep on a pillow at night so they don't get bedtime or nighttime reflux. But that is a real symptom that people have to treat. And the last thing I'll add, since I think we know who this patient is that overall the stents are well tolerated. About 80% of patients will say that they don't feel the stent, that they don't know it's there. But a small subset of patients will feel some chest pressure or some chest pain after the procedure. We tell them about it up front so that they're prepared for that possibility. We try to medicate them through that symptom if that occurs to see if we can allow them to continue to eat. And in most cases, patients do tolerate it. Very rarely the pain is so significant or so severe that we sometimes remove the stent and discuss other options.
Let's move on to what happened next, and then we'll have Dr. Molina comment.
So let's continue with the case. So this patient had a stent placed, and he had improvement in his dysphagia. And then he started pembrolizumab on compassionate use with improvement in his liver and nodal metastases. And he felt very well with the stent initially, but over the next year it needed to be replaced multiple times due to stent migration. Eventually he had endoscopy as shown here, and he has evidence of stent erosions. He develops chest pain and the stent's removed, but he continues to have severe dysphagia, and so the stent's replaced again. Overall, his CT scan is stable. He has evidence of treated liver metastases and overall no progression, but still continues to have this dysphagia and weight loss. So now what do we do with this patient? He's had persistent dysphagia. He's already received chemo-RT. He's had multiple stents placed and removed.
And it's been a year, and the liver metastases regressed, were sub-centimeter at this point, and treated. So squamous cell cancer on pembrolizumab. Daniela?
Mm-hmm. Well, we know the patient well, so I want to make a comment about the before. So I think the role of surgery, for palliation, I think that surgery is a immunocompromising type of procedure, and so I think that if the patient has any chances of going on an other type of treatment, like this patient went on Pembro and did very well, I would not offer surgery for palliation. It would not, it's not worth it if we have alternatives. Comment about feeding tubes. I think gastrostomies are very different than jejunostomies. Patients hate jejunostomies. They have to use a pump at night to be fed. It's just really affect their quality of life enormously. And this patient had a very extensive tumor into the stomach, so possibly the gastrostomy was not an option. So now he had the stents, and stents, let me tell you, the stents really favor fibrosis and a lot of reaction, like inflammatory reaction. So even in patients that had chemoradiation as a neoadjuvant approach and had a stent placed during the treatment, when they come to surgery, their surgery is a lot more difficult. There's a lot of fibrosis around the stent.
It's an important teaching point. Yeah.
It's a very important teaching point. So if the patient has a hope for curative esophagectomy, I try to manage it without a stent if I can, because the surgery is easier. If the patient had no hope for curative treatment, that it really, I think the stent is a great option because it preserves the ability of the patient to eat. Now in this situation, now we have a patient has no signs really of disease at this point, but we know he had stage 4 at some point, and now he can't eat. His quality of life is seriously affected by this fact. He tried the stents. He did not want a feeding tube. He had a feeding tube actually at some point. He had a jejunostomy, so he knows what feeding at night looks like, and he does not want that. And so, it's a patient that we discuss in our multidisciplinary. It's not something you want to take easy. You want to have a very good discussion to understand what is his prognosis what other options are available before you take him for a potential really, really tough surgery. And so we decided to operate on him.
Ryan, what happened?
So the patient underwent esophagectomy. There was no evidence of any disease intra-abdominally, and frozen sections during the surgery showed only fibrosis. And the final pathology is here. Here's the gross pathology and some representative microscopic slides. And what we saw is that there was some ulceration and a fissure and extensive mural fibrosis compatible with therapy-related changes and his clinical stenosis, but no evidence of any viable carcinoma. On the right side is a nodule that was seen, but this had either dead tumor or perhaps a lymph node with therapy-related effects. But again, no cancer was seen. So this was staged as a YPT0N0 pathologic CR, at least for his primary tumor.
I
Was
want to
there
make a
anything
comment.
interesting on genomics?
So I believe this patient had a P53 mutation, but nothing.
Squamous histology, and there was no, it was non-MSI, non-ABV positive cancer. Just goes to show that, foreshadowing that we're not that good at predicting who's going to have these outlier responses.
Yeah, and right
I
now
wanna-
we don't have regulatory approval yet for squamous cancers. I mean,
Right.
for PD-L1 esophagogastric that's refractory to chemotherapy, with a 1% threshold there, we can offer the drug to these patients. But this would be a case you'd have to get compassionate release, which you did.
Right.
I want to make the comment, while you're doing the operation, you have no idea if there is any cancer left. I mean, this is easy now after the specimen is removed. But while you're there, his surgery was very, very difficult because his original tumor was very large, and so everything was like, we say, it was like cemented together there. So if I knew there was no cancer there, I might have just been able to bypass that area and leave some of this behind, but I had no idea. So really, we need better technologies or better instrumentation to understand what's cancer, what's no cancer while actually doing the operation. Because we end up taking the pericardium, we end up taking some of the diaphragm, and actually I was a little nervous, but I had to leave a little muscle piece on the aorta because I just couldn't remove it. The other thing to keep in mind, like I did not reconstruct him as a standard gastric pull-up because I didn't know if there was any tumor that would have recurred in that location and then obstructed my stomach. And so then I've done the surgery and put all those through risk for nothing. So I actually put the stomach behind his sternum, so a totally different routing to avoid, the stomach then to be compromised. So those are all very complicated, complex thoughts that you have to, keep in mind while you're doing surgery like this, like for palliation.
How long was the surgery?
It's about 10 hours. It's very tough.
Really heroic effort here. Let's hope we can help him.
I'd like to just add that it sounds from this presentation like this was a very easy decision and we moved through this very, very rapidly. This
Everyone knows
went
this
for
patient very
months.
well. Yeah.
This
Years.
went on for months.
Years, really.
This patient had multiple stents put in, multiple stents repositioned and removed, et cetera. We really struggled for a long time with decisions on how to manage this until finally we really felt compelled that there weren't many other good options.
And so the first thing when I went in, I did laparoscopically first because I thought I'm going to find carcinomatosis. Like I thought that's why he doesn't tolerate the stent. There is obstruction distally. So I did a very extensive, careful evaluation, and I took some biopsy of the liver and the peritoneum. Everything was negative. Everything was fibrosis.
And that's how we found initially the Mets. It was on the laparoscopy and biopsy. So that
Yeah, I had
really-
taken him for surgery a year before. That's kind of, like a very happy ending story in a way, because a year prior, in September last year, I took him for surgery for esophagectomy, and I found the liver met, and I biopsied and I quit because I thought, it's not worth doing it. And now a year later, we actually operated on him, and there was no residual disease in his liver and his peritoneum, and even in the mass, there was no residual disease, which was very surprising.
And it's interesting, to your point earlier about radiation, role of radiation in this disease. I know Karen is sitting in the room as, his tumor was radiated in the past. And there's going to be another case we're presenting later on where this appears to be the theme. That's a great question also, and I don't think Jackie's in the room, and Laura left. But in esophageal squamous cancer, we generally don't see HPV positivity, at least in the US. And what was unusual histologically about this tumor is that it's a distal esophageal tumor. It wasn't a proximal or mid-thoracic esophagus cancer, as we generally see with squamous cell tumors. And this was purely squamous cell, not the admixture of adeno and squamous. So unusual situation. Okay, great. So why don't we take a break, and then we'll come back to our next session. Great job, Brian.
Right.